So hi again. So my name is Ryan Darson. I'm the academic officer here for Leicester Radiology Society. So today my presentation will be on abdominal imaging. And this presentation has been reviewed by Dr. Vikas Shah, who's a consultant radiologist at the University of Leicester. He'll also be here in this session today. So if you have any questions throughout this presentation that you would like to ask, me or him will be happy to answer as well. Just a few things before we begin. So first of all, I hope that you've scanned this QR code just for feedback, and this will help you get a certificate at the end for participation as well as spectator as well. So this session will be recorded and will be put on YouTube, so it can be watched later. So if you want to review it, and I'm going to try and make this an interactive session, so there'll be interactive cases as well. So you can put any answers or any questions that you have onto the chat. Okay, so what we'll go through today, so how to interpret abdominal x-rays. We'll have 5 cases, which will be x-rays, and then 3 cases, which will be CT, and they're just a summary of everything. So here we have a normal abdominal x-ray. So before we look at pathology, it helps us to remind ourselves of what a normal abdominal x-ray looks like. So recognizing normal makes abnormalities stand out immediately. So there is a standard approach which I'll go through afterwards, but just a few things to recognize here. So you've got the liver on the right upper quadrant, the splenic in the left upper quadrant, the ascending colon and descending colon, and then the sacroiliac joints, as well as the femurs as well. So how do you interpret an abdominal x-ray? So whenever we look at abdominal x-ray, the key is structure. So abdominal x-rays can appear chaotic, so following a systematic approach prevents you from missing important pathology. So first, I always like to start by checking the patient's details, so their name, their date of birth, their NHS number, and the date of the image. And then you can compare with any other previous imaging. This is important because chronic changes can look worrying if you don't realize they're long-standing. So then I assess the projection. So most abdominal x-rays are supine AP, but sometimes you'll get an erect x-ray if you're looking for free air. But remember, supine abdominal x-rays are poor at detecting pneumoperitoneum, which is air in the peritoneum. So then afterwards you look at exposure and then abdo-X. So what is abdo-X? So this is a mnemonic that we use in Leicester. It's quite useful to use. So A is for air. So you look for where air should be. So for example, the stomach, small bowel, and large bowel, and where it shouldn't be. So such as under the diaphragm, in the biliary tree, or outlining organs. So then B is for bowel. So here I assess the bowel position, the caliber, and the wall thickness. So is it central? Is it peripheral? Are the folds traversing the entire lumen or not? D is for dense structures. So this includes bones, calcifications, so for example, renal stones, gallstones, and also foreign bodies. So O is for organs. So although soft tissues are harder to interpret on an abdominal x-ray, you can still identify organ outlines. For example, the liver edge and the splenic area and the psoas shadows. So for example, if you have absence of these things, could be a sign of retroperitoneal pathology. And then X for external objects and artifacts. So things such as drain tubes, stents, surgical clips, catheters. So this can all be given in clues about the patient's history as well. And by running this system every time, even subtle abnormalities becomes much easier to spot. And a few things I want to mention just before we begin the cases. So for abdominal x-rays, they're used fewer and fewer nowadays because CT or ultrasound is now preferred as first line. But so there are very few indications for abdominal x-ray, but it's still examined by the GMC. So we'll just go through a few cases because of this. Okay, so we'll start off with case one. So we've got a 70-year-old presenting to the emergency department with a 24-hour history of severe abdominal pain, bilious vomiting, and absolute constipation. So they've got a past medical history of an open appendectomy 20 years ago. On examination, the abdomen is distended, tender, with high-pitched bowel sounds. So there are no signs of peritonism, for example, guarding or rebound tenderness. The vital signs are a heart rate of 110, a blood pressure of 130/85, and a temperature 37.2. So first of all, what investigations would you like to do? So if you could put your answers in the chat, you can take some time to think about this. Okay, look at the chat. Using these good. FBC's lactate. Okay, so giving you some time to think. Okay, so initially you would like to do an A2E assessment, for example, to check for signs of hypovolemic shock, bowel ischemia or perforation, sepsis. Then you want to do urgent bloods and a group and save as well due to third spacing. You should do a user needs to look for metabolic derangements, which may be due to vomiting or dehydration. You would like to do a VBG, which can look for raised lactate, which can be signs of ischemia. Here is an abdominal X-ray shown here, but CT with IV contrast is the imaging of choice. So in this image here, what is the main finding that you can see on the X-ray? Okay, so that could be a potential, Ralph, small bowel obstruction, yeah. Is there any specific finding that you can see on this X-ray? Okay, descended bowels, yes. There's a certain name for these lines. Okay, perfect, Sophie. So, first of all, what stands out, as someone's mentioned before, is the multiple dilated loops of small bowel, which are arranged centrally. So the key features confirming a small bowel is the presence of varvulae conaventes, which is the mucosal folds that traverse the full width of the small bowel lumen, which becomes more prominent and spaced closer together. So, what are some causes of small bowel obstruction, just to test your knowledge? Yeah, hernias is one. Linksy, good. Adhesion strictures, perfect. So, to be fair, you've said most of these already. So, adhesions, which would be most likely in this case, because the patient had a previous appendectomy 20 years ago. So hernias, malignancy, which is more commonly seen in large bowel obstruction, but can still be a cause of small bowel obstruction. Strictures, which could be secondary to Crohn's, and in younger children as well, intussusception, which is tunneling of the small intestine. So what would be your initial management for this patient? I'll give you guys some time to think. Okay, good. Cushy, no by mouth. NG tube, yes. Okay, so as two of you mentioned already, so nasogastric tube decompression with free drainage, which is also known as drip and suck. And you give IV fluids, because they might be very dehydrated. You want to make them nil by mouth, as they may be vomiting as well. And you want to make sure they have adequate analgesia and also correct their electrolytes as well. So surgery is also considered, but this is when there are signs of peritonitis or ischemia. So they might have signs of fever, tachycardia, hypertension. Then perhaps surgery could be done first, but we always manage conservatively first. So how would you differentiate between small bowel and large bowel obstruction radiologically? And if you do have any questions, feel free to put it on the chat. Large, small peripheral. Yep. Okay, so we'll go through the differences. Okay, so difference between small bowel and large bowel obstruction on an X-ray. So, as someone's mentioned, so small bowel is more central, whereas large bowel is more peripheral. So, like we mentioned before, the small bowel has the valvae conventores, whereas large bowel has these haustral folds. And in small bowel, they contain air or fluid, whereas in large bowel, they contain air or feces. So this is what it's seen. It's more central here. I don't know if you can see my mouse, but it is more towards the center, whereas in the large bowel, it's more in the peripheries. Okay, so there is this rule called the 369 rule. So this 369 rule is the easy way to remember the maximum normal diameter of bowel on imaging. So this can be applied to abdominal X-ray or CT. So small bowel is 3, colon is 6, and cecum is 9 centimeters. So the relevance of this is that if the diameter is bigger than these limits, you start thinking about bowel obstruction, and this can obviously lead to a risk of perforation as well. Okay, so that was case one done. If there are any questions, feel free to put in the chat. Me or Dr. Shah would answer this for you. Then if not, we'll be ready to go to our second case now. So we have a 70-year-old woman who presents to the emergency department with sudden severe abdominal pain that started 6 hours ago. The pain is constant and worsened by movement. She reports nausea but no vomiting. She has a history of diverticulitis and chronic constipation. So on examination, her abdomen is rigid, tender, and distended with absent bowel sounds. Her vital signs are heart rate of 120, blood pressure of 85/55, and temperature of 38.2. Can I just put that on just for a little bit? Okay, so what is this finding? What is the main finding on this abdominal X-ray? So I'll give you a bit of time for this. And thank you for engaging in the chat. Okay, constipation. So there's a certain sign that can be seen here, just as a little hint. Yes, Wigler sign. Okay. So this abdominal X-ray shows Wigler sign, which is also known as the double wall sign. So normally we only see the inner wall of the bowel, but when free air is present, both sides of the wall become visible, outlining the bowel like a tube. So like these arrows that are pointed here. So risk factors in this patient, such as diverticulitis, can make perforation very plausible here. So I also want to emphasize that an erect chest X-ray is usually better for detecting free subdiaphragmatic air, so air under the diaphragm, but an abdominal X-ray can still show enough to prompt urgent action. So what are some complications of diverticular disease? These questions aren't related towards radiology, but it's good to test your knowledge. Okay, so anemia from chronic blood loss. Diverticular abscess, perforation, sepsis fistula, good, perforation, okay, good. So some of these complications are diverticulitis, so hemorrhage, so as you mentioned, Sophie, could lead to anemia. So development of a fistula, perforation, fissure formation, abscess formation. So those are all good. Any questions at all based on that? If so, please put it on the chat. So what are some risk factors for diverticulitis? Constipation, straining. Good. So we can have as well as that. So constipation would be good. So age, lack of dietary fiber, which would lead to constipation, obesity, so especially in younger patients, smoking, and as well as this, NSAID use. So I just wanted to highlight you what diverticulus is, how it shows on a CT scan. So I point it out just to help with this, but it's these small black areas here, which is air-filled dark outpouchings from the colonic wall. And these are signs of diverticulosis. And yeah, so now moving on to case 3. So we've got a 45-year-old man with a history of ulcerative colitis who presents with a 3-day history of severe abdominal pain, bloody diarrhea, fever, and lethargy. On examination, his abdomen is distended and tender with absent bowel sounds. So his vital signs are a heart rate of 130, a blood pressure of 90/60, and a temperature of 39. I'll just put that on. Okay, so another main finding question. So what is the main finding on this abdominal X-ray? So this one's a bit harder than the others. Okay, someone's put toxic megacolon. Okay, and why do you suggest that, Ralph? Okay, yes, true. Okay, so on this abdominal X-ray, so the key features are massive colonic dilatation without obstruction, and the colon also appears smooth because we lose the haustra, which is the lines, which is a classic UC appearance, also known as lead pipe colon. So that's on this side. Don't know if you see my mouse. I don't know. Can someone let me know if they can see my mouse or not?
Yeah, we can.
Okay, perfect. Thank you. Okay, so right here is the toxic megacolon, and here there's the loss of the lines, which is normal of the colon. So this is loss of the normal haustral markings. So it looks like a lead pipe. Okay, so this is another X-ray of a patient with UC. So what can be seen here? Okay, so this one's much harder. So here, the slide shows mucosal islands, which is seen as severe inflammation. So what this is, there are little islands of preserved mucosa surrounded by ulcerated mucosa. And this is a medical emergency because toxic megacolon is here as well. And this carries a high perforation risk and will need urgent escalation and surgical involvement as well. Okay, so I've got case 4 now. So this is a 17-year-old female who's presenting with diarrhea and abdominal pain. She's also passing some blood and mucus in stool. So what is the main finding on this X-ray? Skip lesions. Okay, so these aren't skip lesions. There's a good guess though. Okay, thumb printing, yes. So what is thumb printing? So thumb printing is they it's mucosal thickening of the haustura, which is due to inflammation edema, which creates thumb printing like projections. So what these things are, it looks like impressions of thumbs pressed into the bowel wall. So this sign is very non-specific, but can also indicate severe inflammation or ischemia. And so what common conditions can thumb printing be seen in? Good. So inflammatory bowel disease. Any others by any chance? Okay, so some other common conditions that thumb printing can be seen in, so that can include Crohn's disease and UC, so someone mentioned IBD, infections, so pseudomembranous colitis, ischemic bowel, and diverticulitis. So what are the radiological differences between Crohn's disease and ulcerative colitis? Okay, good. So Crohn's is mouth to anus, so you will see lesions towards those areas, okay? So for Crohn's disease, you can see fistulas, you can see strictures. So this is known as Cantor string sign, which is the string-like appearance here. You can get proximal bowel dilatation. You can get rose thorn ulcers. And then in UC, you can get loss of haustura. You can get long-standing disease. So the colon is narrow and short, which is known as drain pipe colon, lead pipe colon. And then you can have superficial ulcerations and also pseudopolyps as well. So this is a picture of a patient with UC. This is just a sign of a Cantor string sign over here. And then we also can use imaging to evaluate for anal fistulas and perineal abscesses. Okay, so this is our final abdominal X-ray case. So we've got a 70-year-old male who has come in with chronic constipation and has sudden severe abdominal pain, distension, and no stool or flatus for 2 days. So an X-ray is performed, and what is the main finding? So let's see a question. So how commonly do people present with X-rays like that? Okay, just go back. So in terms of X-rays like this, it's quite severe extension because it's got multiple findings of the lead pipe here, but and it's more and then lower near the end of the rectum. So it is quite unlikely, but there are some signs that can be seen. And for imaging itself, these are the findings that you get in examinations as well, being like this is the lead pipe colon, suggesting UC or some sort of inflammation as well. So I'll just go back to this. So people said sigmoid, sequel volvulus, volvulus, coffee bean sign. Okay. So yeah, so this X-ray shows the classic coffee bean sign. You can see here, which is a massively dilated loop of sigmoid colon, which forms that coffee bean shape. So they're large dilated loops of colon and often with air fluid levels as well. So what is the management of sigmoid volvulus? So management can be based on if there are signs of peritonitis or perforation or if there aren't signs. And thank you, Dr. Shah, for answering some of the questions in the chat. Okay, so as I mentioned, so if there are no signs of peritonitis or perforation, most patients can be treated with decompression, which involves using a rigid sigmoidoscope and by placing a flatus tube. However, if there are red flags such as peritonitis or perforation, fever, elevated lactate, then you can perform emergency laparotomy and a Hartmann's procedure. So this is removal of the rectosigmoid colon and then the formation of an enclostomy, which is a stoma. So I just wanted to show you sigmoid volvulus on a CT scan. So it's this here, which is a swell sign, sorry, a well sign, and this can show sigmoid volvulus on a CT, and this is a CT with contrast right here. Okay, I just wanted to quickly mention the difference between a sigmoid and cecal volvulus. So as we talked about, sigmoid has got the coffee bean, and it also has a normally positioned cecum, whereas in cecal volvulus, there's no normal cecum, there is a normal sigmoid, and you get reverse C shape right here. So that's how you can tell the difference between sigmoid and cecal. Okay, so that was all of our abdominal x-rays. So now we're going to move on to CTs. So this slide shows just cross-sectional images of the abdomen. So the key message that I want to get out here is that CT gives far more information than abdominal x-ray. You can appreciate the bowel gas pattern, but also soft tissues, vasculature, and the retroperitoneum as well. This is what x-rays can't do as well. So CT interpretation should always follow the same rule and the same principles as abdominal x-rays. So you go through each system. So liver and spleen. What is the size? What is the density? Are there any lesions present? So the biliary system, look at the ducts, look at the gallbladder, look at for stones as well. The pancreas, look for inflammation for pancreatitis, look for necrosis or any collections or abscesses. You can look at the kidneys and ureters, may show hydronephrosis, stones or infections. You can look at the vessels. So you got the aorta right here, which is quite important. You can see the celiac trunk if you go further down. And then the bowel itself, looking for any wall thickening, any obstructions, any pneumatosis, any free fluid, or any free air as well. So why do we request CT scans? So as I mentioned before, this is now the first line imaging modality for most acute abdomens. So they are useful. Abdominal X-rays are useful in very narrow range of scenarios. But a CT outperforms abdominal x-rays, as I mentioned before, free air, free fluid, small bowel obstruction. So that can show signs of ischemia. And in terms of free fluid as well, I should have mentioned that it's important in trauma if you have like a splenic injury or sepsis itself. And then inflammatory pathology, so for example, appendicitis, diverticulitis, or pancreatitis. CT is more accessible out of hours, which is why it has replaced abdominal x-ray in many acute pathways as well. I'd also like to add that CTs are also less operator dependent than, for example, ultrasounds, because anyone can interpret a CT retrospectively, whereas ultrasound findings are lost the moment the probe is removed. So that's why they normally prefer abdominal CTs, but ultrasounds can be used for determining stuff, for example, the biliary tree, so the gallbladder and stuff like that. any pathology associated with that. Okay, so we've got another case. So we've got a 70-year-old man who presents with a 1-day history of worsening lower abdominal pain, vomiting, and a progressive swelling in his left groin. He has not passed stool or flatus for 24 hours. So on examination, his abdomen is distended with high-pitched bowel sounds. His vital signs are a heart rate of 110, a blood pressure of 100/65, and a temperature of 38.2. So what can be seen on this CT scan? Yeah, so someone mentioned a left-sided hernia. Okay, good. So the main finding is you see a loop of small bowel right here, which is protruding through the wall, and this confirms an inguinal hernia. So it's important to note how it's dilated proximally and collapsed distally. So this is a hallmark of an obstructing lesion. You see free air all over here. And the CT is important here because you can see these air pouches here. And then as well as this, the CT is also important because not only can you check if the wall is thickened, and edematous or poorly enhancing, and this can also suggest if a hernia is strangulated and need for urgent surgery. And I'll go through these terms later. So I just wanted to quickly talk about the difference between indirect and direct inguinal hernias because sometimes people confuse them. So I want to go through them quickly. So indirect inguinal hernias. So just quickly about the pathology. So hernia sac enters the deep inguinal ring and then it travels through the inguinal canal and it may exit via the superficial ring into the scrotum for males. It passes laterally to the inferior epigastric vessels and normally follows the path of the processus vaginalis. So the causes of indirects are usually congenital. So for example, a patent processus vaginalis that fails to close. It is more commonly seen in younger patients and is also more common than direct. The swelling often appears from the deep ring and can also extend into the scrotum. It is also more likely to strangulate as well than direct hernias because it has a narrow neck of the deep ring. So for example, for direct, this is the hernia pushes directly through the wall and not via the deep ring. So it occurs within Hasselbalch's triangle, which has a few borders. So medially, it is by the lateral border of the rectus abdominis, laterally by the inferior epigastric vessels, and inferiorly by the inguinal ligament. So the hernia, where it passes medial to the inferior epigastric vessels, whereas in the indirect, it passes lateral. So the cause is acquired weakness of the abdominal wall. So could anyone think of any examples of what might cause a direct inguinal hernia? So what might cause an acquired weakness of the abdominal wall? Okay, so some causes can include chronic cough, heavy lifting, constipation or straining, and sometimes even age-related muscle weakness. It is more common in older men, and it also has a wider neck, so it's less likely to strangulate than an indirect. So just quickly talk about incarcerated versus strangulated. So these terms could describe the state of any hernia, so inguinal or femoral, not just direct or indirect. So incarcerated, the herniated contents are stuck and they cannot be reduced back into the abdominal cavity. The main thing which differentiates between these two is for incarcerated, the blood supply is still intact. There is no ischemia yet. So features, they may include a painful firm swelling and irreducible in examination. The skin is normally normal in color, and patient will not or may not have obstruction symptoms. So this can still progress to strangulation, so it does need a surgical review. Whereas for a strangulated hernia, these herniated contents have compromised blood supply due to constriction at the neck. So they could have features of severe constant pain at the site of the hernia. They would have the mass would be very tender and would not be able to be pushed back in. The overlying skin may be red, warm, or discolored. There will be signs of bowel obstruction, for example, vomiting, distension, and absence of stool or flatus. And they may even show signs of systemic upset, for example, tachycardia, fever, and hypertension. This is a surgical emergency as there's a lack of blood supply, so this does require urgent operation to relieve the constriction, and you also need to assess bowel viability to see whether the bowel can be saved. So it's important to note that radiologically, we cannot diagnose incarceration. However, we can see signs of strangulation. So, for example, bowel wall thickening, edema, and free fluid within the hernia sac. So I know I've gone through quite a lot about hernias, but I just wanted to make sure that I had a full explanation of what these terms meant, because they are used quite commonly when describing hernias. Okay, so case 7 now. So we've got a 72-year-old man who has had a history of hypertension and heavy smoking, who presents with sudden onset severe central abdominal and back pain. He feels dizzy and has nearly collapsed at home. On examination, he appears pale and sweaty, with a tender pulsatile mass in the midline abdomen. So he's got a heart rate of 125, blood pressure of 80/50, a rest rate of 24, and temperature of 36.8. So what is the main finding on this CT scan? Okay, good. So what can be seen here, right here is the abdominal aortic aneurysm. So the inferior renal aorta is dilated and elongated as well. And there's also a lumen field of contrast, as well as a thrombus as well, which is just seen here. So what is an abdominal aortic aneurysm? So normal abdominal aorta is less than 3 centimeters in diameter. So anything above this can be classified as an aneurysm. So we normally categorize them by size, because size normally correlates with rupture risk and also guides management as well. So the mortality of a ruptured AAA is around 80%, so it is quite important that we catch these quite early. In terms of their size, so normal is less than 3, small is between 3 and 4.4, medium is 4.5 to 5.4, and large is above 5.5. These numbers are quite important and you will need to know them. So most abdominal aortic aneurysms are detected incidentally or on screening in men over 65, and once diagnosed, a follow-up with ultrasound is the key, which I'll go through now. So this slide basically shows the standard screening and follow-up protocol. So if they're less than 3 centimeters, there's no further action, there's not a risk. If it's between 3 and 4.4, they need to rescan every 12 months just to see how it's progressing over time. If it's between 4.5 and 5.4, you need to rescan every 3 months. And if it's over 5.5, it would suggest large aneurysm and they need to be referred within 2 weeks to vascular surgery. It's worth pointing out that modifying risk factors, for example, smoking cessation, blood pressure control, could significantly impact progression and can help. So there are 2 main repair options for AAA. One being open repair via laparotomy, which is more invasive, or endovascular aneurysm repair, which is quicker recovery but does require lifelong imaging and follow-up for leaks. And the way they do this is they insert a stent via the femoral arteries. So criteria for elective repair, so they operate if an abdominal aortic aneurysm is over 5.5 centimeters in diameter, it's expanding at over 1 centimeter per year, and if it's symptomatic, if they're experiencing symptoms. So the main complication of AAA is aneurysmal rupture. But there are other complications, but less common, which involve retroperitoneal leak, embolization, and an aortoduodenal fistula. So for ruptured AAA, there is a classic triad of severe abdominal or back pain, hypertension, and a pulsatile abdominal mass. But normally in clinical scenarios, they normally present with a loss of consciousness. They can also present with collapse and also the presence of shock, so hypertension and tachycardia. So for immediate management, they will need to have high flow oxygen. They will need to have two large bore cannulas. They will need to have immediate bloods. So for example, FBC usually is in clotting, and they will need to be cross-matched for minimum 6 units. As well as this, they will need urgent vascular surgery involvement. So I think this picture describes a rupture AAA. So the aorta's here. You see the retroperitoneal leak and the free fluid from the aorta and the rupture. You can also see some calcification as well. Okay, so we'll get into our final case now. So this is a 55-year-old man who presents with 8 hours of severe right flank pain radiating to the groin. The pain is colicky and associated with nausea and vomiting. He reports reduced urine output but no dysuria or fever. On examination, he's in distress from marked right costovertebral angle tenderness and a soft, non-guarded abdomen. So he's got a heart rate of 100, a blood pressure of 140/85, and a temperature of 37.6. So from this history itself, what is the most likely diagnosis? Okay, great. Okay, so some people want to put renal colic in the chat. So yes, so the most likely diagnosis would be an acute renal colic secondary to ureteric calculi, which is most likely a right-sided based on the symptoms of right-sided pain. Um, Other things that might help differentiate this, so they have the classical features of sudden colicky flank to groin pain, nausea, vomiting, and as well as this costovertebral angle tenderness. So what are some key differentials that you want to include as well as rule out for this patient? Okay, pyelonephritis, good. Mm-hmm. Okay, so some key differentials. So pyelonephritis, so they would present with pain as well as fever. A ruptured AAA, this is always important to rule out in older patients as well. Musculoskeletal pain, diverticulitis, and testicular torsion, which can also give referred pain. So even though renal colic is common, please don't anchor your diagnosis prematurely. Please try and rule out other diagnoses just to make sure. So what initial investigations should be performed and why? So I'll give a bit more time for this question. Okay, great. Someone's mentioned non-contrast CT, urine dip and culture. Okay, so there's a few to right answers. So urine dipstick and culture. So urine dip is essential. You might see microscopic hematuria, so blood in the urine. But if there is an absence of this, it doesn't exclude a stone, so please be aware of that. So you want to check serum creatinine and electrolytes. So this is just to check renal function. You want to do a full blood count CRP, which just rules out infection or inflammation. You can also do a calcium urate, which can show any underlying metabolic causes or maybe the composition of the stones. And like someone mentioned in the chat, so you can do a non-contrast CT KUB within 24 hours. And this is quite sensitive and also gives the stone size and location, which also guides management. So in pregnant women and children, ultrasound is also first line. So this is just to rule out any sort of unneeded radiation. So right here is just a CT scan of this patient, which does support the diagnosis of right ureteric stone, which I've highlighted here. So what is the first line analgesia for suspected renal colic? Okay, so someone's mentioned diclofenac. So NSAIDs are recommended first line by NICE. So traditionally, you do give IM or IV diclofenac. You can also give PR diclofenac. Consider also giving cardiovascular, or also consider checking the cardiovascular risk when choosing NSAIDs, because some NSAIDs are contraindicated. For example, celecoxib. So if NSAIDs are contraindicated or ineffective, you can do IV paracetamol, and you can also consider opioids only if other treatments fail. So let's say the patient's stone is less than 5 millimeters. What is the likely management? Okay, so someone's mentioned watch and wait. So yes, so what we'd like to do is do watchful waiting because most stones under 5 millimeters normally pass spontaneously, so usually within 4 weeks. Analgesia, so like we said, NSAIDs or hydration. And then we also want to consider alpha blocker if it's a distal stone, for example, tamsulosin, which can promote smooth muscle relaxation and that can help facilitate the passage of the stone. So what are the management options for stones over 5 millimeters according to NICE? So there are a few management options, so if you can mention some of them. Okay, so some management options. So if they're less than five, like we mentioned, watch for waiting. If it's between 5 to 10, you can use shockwave lithotripsy. So what this is external shock waves which fragment stones. There are risks of organ injury, ureteric obstruction from the fragments, and this is normally quite a painful procedure, so there normally requires analgesia. If it's between 10 and 20, you could use shockwave lithotripsy or uretoscopy. So what this is when you use a scope, which is passed retrograde into the ureter or pelvis, and this is used when shockwave lithotripsy is contraindicated, for example, in pregnancy. And then normally there is insertion of a stent, which is left for around 4 weeks. And then over 20 millimeters, you have percutaneous nephrolithotomy. And this is when you have access through the skin into the renal collecting system. And this can help drain the urine. So for ureteric stones, you can use SWS or alpha blockers. Then if it's 10 to 20, you could use ureteroscopy. So what general advice can you give to the patient to help reduce recurrence? Just general management. Okay, someone's mentioned more fluid. Okay, so what general advice? So as I mentioned before, so high fluid intake and reducing salt. You could also avoid carbonated drinks, and you could also give lemon juice or citrate supplementation, which can reduce stone formation as well. And it's important for patients who form a stone because they're at high risk of recurrence. So counseling does matter, and giving general advice can help them prevent coming into the ED or emergency department again with these symptoms. Okay, so I just brought up this case again, and I just wanted to ask, so what features in this case would make you worry about complications of a renal stone? So what do you see here that might be some worrying signs for the patient? So there are a few things here. So you've got the reduced urine output, which could suggest obstruction or an AKI. You've got the tachycardia, heart rate of 100 and vomiting, which could suggest dehydration. That could also lead to an AKI. And I know I haven't mentioned this, but also the temperature is slightly raised. So fever may suggest an infected obstructed kidney, which is a urological emergency because patients can deteriorate rapidly into sepsis. So they do require urgent decompression with either nephrostomy, which is where you put a tube inside to help drain the urine, or a stent and IV antibiotics is important. Okay, so just before we end things, I just wanted to mention that when we use CT scans, sometimes they do involve using IV contrast, and things that you need to remember when patients are needing contrast is that you need to check their EGFR. So if their EGFR is low, they might not be able to withstand the contrast as it can build up in the kidneys, if they have an allergy to the contrast, or if they are pregnant. So those are the three case or scenarios where they can't give contrast. I didn't also mention ultrasounds or MRIs in this presentation, but ultrasounds are also great for right upper quadrant symptoms, for example, gallbladder issues. And then MRIs as well, they have excellent soft tissue detail. So you can look at the biliary tree, liver, or bowel as well. So I just want to say thank you all for participating as well and watching and making this an interactive session. I hope this session was useful and has given you more confidence about reading abdominal imaging and understanding main pathologies. So if you're able to fill out this feedback form afterwards, just to ask a couple of questions, and we can fill out certificates for attendance after you filled out both forms. So this form on the bottom right here is if you missed the start, this is a pre-feedback form. I also like to mention that we do have a radiology conference on the 15th of February 2026, which will be held in Leicester. So this will involve talks about careers in radiology, the involvement of AI and how that could be interpreted here, and a few guest speakers as well, and a few workshops, so hands-on things. So would recommend you going. In terms of resources, there are two resources here. So lmsradiology.org. So this is for Leicester Medical School, and they have like good lectures, online lectures, and free teaching resources about pathologies. And there's also this Radiology Basics iBook, which is free and which you can download via Apple Books, or you can access the web version. This can also help with just more resources just to test your knowledge as well. But yeah, just so thank you for your time.